see your names at least, even if I can't see your faces right now. But my name is Margaret Sewell. I'm the director of the Education and Engagement Core and the ADRC. And I'm here on the screen. You can see Dr. Luizos, an assistant professor and a member of our ADRC faculty, Dr. Judy Neugroschel, the director of our clinical core, and of course, the director of the ADRC, Dr. Mary Sano, who's going to be speaking with you in just a couple of minutes. So for those of you who don't know, we typically do these lectures in person, but over the last year, we've been doing what we call ADRC lunchtime talks on Zoom, which has given us an opportunity to share with you what's been going on in the center and how that's been changing over time. And of course, today we have this very important talk about this new medication, Aduhelm, that Dr. Sano is going to speak about in a moment. Just a couple of housekeeping issues before I turn it over to Dr. Sano. One is, if you are new to the ADRC and coming to this talk and you are not a member of our registry, meaning you're not getting information about our educational outreach and our newsletters, and you would like to, please just shoot an email to Dr. Luizos, who you RSVP to come to this lecture. And we'll add you into our registry so that you make sure you don't miss any upcoming talks and our newsletter and other educational events we have in the ADRC. The other thing is, you can see that we're recording this lecture so that if some things go over your head or you're not able to stay the whole time, we will be posting a recording of this lecture on our website within a couple of weeks of the lecture today, so you'll be able to watch it again. Since there's so many people here today, we're going to use the chat feature to take questions at the end. And just a reminder, if you're not familiar with this, the chat button is down at the bottom of your screen, right in the middle. And if you click on chat, you'll be able to write in a question, and I will take those questions and share them with Dr. Sano so that we can answer as many as we can. If we don't get to everybody, always, I say, you can email us and we're happy to respond individually. We will have some polling questions about your response to this lecture and also some other things you might like to hear about. And we'll do those polling questions right before we take the Q&A at the end in case you're not able to stay for the questions and answers. So I think that's about it for what I need to talk about. Again, I'm so happy to see so many people here and to hear Dr. Sano talk about this important issue. And I'll hand it over to you, Dr. Sano.
Well, thank you, Dr. Sewell. It's really nice to do this talk once again. I'm thrilled to have so many people attending. And I think we have to all accept it's really a monumental moment, and we really need to stay on top of information to be able to use the discoveries we've made most usefully, to make sure that we use them properly and to be sure we share the information. So let's see, why is it not advancing? There we go. I always begin my talks by reminding you that in addition to the work I do at the Alzheimer's Disease Research Center at Mount Sinai and at the Bronx VA, that I also do consulting work for firms, including for Biogen, the firm that has made this drug that we're hearing about today. So I want to begin by talking about the timeline, and at the top is where we are now. But I want you to take your attention down to last fall. In November of last year, the full application submitted by the drug company Biogen to the FDA requested a consideration of this drug for approval. That was followed by a period of time on November 6th when there was a full public review with the FDA advisory board giving its opinion on the approval of this drug. There was an expectation that we would have an announcement by March, but in January, the FDA informed them that they would need a 3-month extension to review the aducanumab data. And then on June 7th, there was an approval by the FDA, something called an accelerated approval, and I will describe that to you. And both Biogen and Eisai worked with the Alzheimer's Association to try to share what they knew about their drug in June of that, on June 23rd, the end of that month. And most recently, on July 8th, the FDA's approval of the aducanumab prescribing data has changed. So there's a lot for us to go over, and I'm going to make sure that I sort of give you the highlights of all of these stages. First of all, it's important to understand what was approved, right? On June 7th, the FDA approved Aduhelm, also known as aducanumab, and you will see both names on the slides, to treat patients with Alzheimer's disease using the accelerated approval process. And so I'm going to talk a little bit about what does that accelerated approval process mean. And the comment is, and we'll go over what this term is, it's used when the drug is shown to have an effect on a surrogate endpoint that seems to be reasonable and may predict clinical benefit at another time. So what is accelerated approval? The FDA allows for earlier approval of drugs that treat serious conditions and that fill an unmet medical need based on a surrogate endpoint. And I'm going to talk about that in some detail. The surrogate endpoint that was used in this study, the marker was amyloid plaque seen on imaging. And it was thought to predict a clinical benefit, but it itself is not a measure of clinical benefit. A change on a surrogate marker, this amyloid imaging, may occur earlier than a clinical benefit, and that's why it's referred to as accelerated. So I wanted to show you some slides that I have shown you in the past, but to put them in a new light. So I'd like you to look here at this graph, and what you see is the increase in certain biomarkers, certain things that might be surrogate markers. Specifically, what you see is a very early increase in amyloid long before there's any impression of symptoms of mild cognitive impairment or dementia. So you could see that this biomarker may actually be a surrogate, but we don't know that for sure. And in fact, when this staging was created and thought about, it was a framework that we were going to study and determine whether or not it's actually accurate. And this comes from a paper back in 2018, just a few short years ago. We've come a long way on biomarkers, and one of the things that's important to recall is that we have approval by the FDA for some of these biomarkers, and I want to talk a little bit about them. So for example, PET amyloid imaging was approved in, I believe, based on data from 2010, it was approved by 2012. And what it told us was that amyloid deposition, which matches the amyloid seen in the brains of patients who die and have Alzheimer's disease, could now be observed in life. All right. There are other ways to measure amyloid, but the amyloid deposition was the biomarker that was used in this, or the surrogate marker that was used in the FDA approval. We also know that there are other biologies that are really important in Alzheimer's disease. One of them is the pathology called tau, and tau can now be imaged imaged in the brain with another tracer. However, that's currently only approved for traumatic brain injury, but it has been used experimentally in Alzheimer's disease. And finally, neurodegeneration, and we have many markers of neurodegeneration. We can tell from MRIs and FDG PET. So we have biomarkers for these three things. One of them is fully approved in this indication. So let's talk about that one in particular. So the criteria for using amyloid imaging is written here. And what we see is in the use criteria, it's used in individuals who have cognitive complaint in a confirmed impairment. So not just, oh, I have a memory problem, but I didn't do so well on a memory test or on a test of like a mini mental test. Also, it's used when AD is possible, but we're not certain, and that can be very often. In fact, in a um, study that was done examining amyloid imaging, more than half of the people who were thought to have possible Alzheimer's disease by i- experts in the area actually turned out not to have amyloid in their brain. Also, uh, the indication is for use when the knowledge of amyloid pathology would confirm a diagnosis and direct management. And so with the advent of aducanumab, we might have a new reason to do amyloid imaging. It's not supposed to be used to determine this dementia severity, or if you're uncertain, you need to do the clinical exam first, and definitely not in people who have no symptoms. Finally, even though it's very useful, it's important to understand that there's a low reimbursement rate at present. It's not approved for a reimbursement in general by Medicare, although that may change. Now, the framework that I showed you was used to create a new biological definition of Alzheimer's disease. At the time of its creation, it was not a diagnostic criteria, but it was a way that we might in the future create a diagnostic criteria. However, it was deemed that it needed validation. Longitudinal studies needed to be done to determine that the clinical condition occurred in the population that had these biomarkers, and that changes in the biomarkers or surrogate markers actually uh, tracked with changes in the clinical condition. And this work really is not yet done. So the proposal is that randomized trials would help us answer that question. Does the intervention move pathology and symptoms? And we don't exactly have an answer yet, and that's what the FDA said. So I wanted to take another look at this framework because it's so important now that we have ways of moving amyloid. What you can see is that for those individuals in this sort of grayish area who have amyloid, right? A plus is amyloid. They are considered to have some form of Alzheimer's disease, whether it's preclinical Alzheimer's disease when they have no symptoms, or whether it's um, prodromal Alzheimer's disease when they have cognitive impairment that you can measure, or when they have frank dementia and they have problems with their activities of daily living. And we can say they have Alzheimer's dementia. So this is what the framework was setting up for us. Now, the thing to keep in mind is theoretically, if I remove the amyloid and it's not there, we would technically say someone doesn't have Alzheimer's disease, even if we hadn't changed the pathology. But that doesn't make great clinical sense, and that's our dilemma right now. So why is there so much controversy about the approval of aducanumab? First of all, the advisory board that I told you about that met last fall did not support the initial application. The accelerated approval that looked at the surrogate markers did not go to the advisory board. And it's not clear to us when it began and who initiated this idea of an accelerated approval. The accelerated approval did not clarify the need to measure the surrogate marker. So in this approval, there's no specific requirement to be sure that the surrogate marker is present. And the approved indication and use don't match in trials and in indication. So we're going to talk about each one of these things because they're all important in understanding the data. So how did the indication and use differ from the trial? So indication and use are what we have in the package insert when something is approved. And the trial is what was done to support that information. So, in the trials, very mild individuals who had a mini mental state exam of 26 or greater. So I don't know how many of you know what your mini mental is or the mini mental of your loved one who might have Alzheimer's disease, but that's very high. In addition, they were very healthy. They had very few comorbidities, and there were many excluded medications. Uh, Anticoagulants, which you might know as blood thinners, were excluded. Comorbidities were excluded that might be quite common in some of our patient populations. In addition, at the baseline, individuals were required to have a positive amyloid scan. They had amyloid imaging scans done, and they were only accepted in the trial if you could view the amyloid on that scan. Additionally, they had their MRI scans were examined to see if they had something called ARIA. ARIA are areas in the brain that suggest microhemorrhages. And we're going to talk more about ARIA in just a minute. But they had to have very few bits of evidence that would suggest that there was ARIA in the brain. And we'll talk about the different types. They had a slow titration based on their person's apolipoprotein E status. We all remember that apolipoprotein E is a risk factor for Alzheimer's disease. And I'm going to review that information, which I know I've mentioned to you many times, and talk about why that might make a very big difference. And finally, there was very frequent tracking of the MRI abnormalities. Now, when the indication or use came out in the package insert, initially there was no severity limitation. It was simply patients with Alzheimer's disease. One reason may be that they accepted the framework without having the substantiating data that says if you have amyloid, you have Alzheimer's disease, and if you have Alzheimer's disease, you have amyloid. So that's a real tricky problem for us right now. Now, later, they've recommended limiting it to mild or moderate. But again, there's no requirement for ensuring that amyloid is present. And there's no contraindications. The entire section on contraindications, even in the updated package insert, which are the directions to physicians about how to use a medication, have nothing in that section. Additionally, there's no limit on how much of this ARIA or microhemorrhage you can have and still take the treatment. It's recommended that you measure it, but there's no limitation written into the package insert. There's no difference in the titration that's recommended depending on your apolipoprotein status. And the MRIs begin at somewhat later intervals, and they're for a shorter overall period of time. So these are big changes, and with so little information known about the full safety profile, you can imagine that this is concerning to those of us who want to use this drug with our patients. So I think it's very important to look very closely at the data and to see what we have. The aducanumab phase 3 studies, those are the studies that were used to support Aduhelm, the same drug with the new name. These are the same studies that were used to support it. And what you can see from this graph is there are many places where the studies were run, but they were very strongly run in the United States, as well as in the UK and in Australia. So the first and foremost data that I want to show you is the data that drove the FDA decision, right? There were two studies that were run. One was the Engage, which happened first, and the Emerge, which started a little bit later. What you can see is in both cases, the removal of amyloid is quite dramatic. And what you're looking at on this graph is the decrease in amyloid. So what you see is in the placebo group, there's little difference. And then when you look at the drug over time, what you see is that both the high and low dose had some changes in amyloid, but the high dose had a very dramatic removal of amyloid in both studies. Now, the next question is, does it slow decline? And here we had a mixed message, and so it's important to think about it. So part of the mixed message is that in the more recent study, the eMERGE study, which had more cases that did not complete, because as you may remember, the studies were stopped because the company thought they had futility, which means no effect. But when they summarized the data they had separately, what they found is that the 78-week interval, the CDR, clinical dementia rating, sum of boxes separated, and what you see is some slowing in the group that had uh, the high dose of aducanumab. Now, there's a few things I want you to see, and that is, please note, there's still worsening. We're still seeing increasing CDR sum of boxes, which as it goes up means poorer performance, all right? In the study that was more completed, the ENGAGE study, you see there was no difference. So we have a dilemma. One study says yes and one study says no, and we should look very closely at the data and see what that means. But first I want to talk about the CDR. The CDR, known as the clinical dementia rating, is a score of 0, 1.5, which means mild or questionable dementia, 1, which is mild impairment of dementia, mild dementia, moderate and severe. And it measures several categories. It specifically measures memory, orientation, the ability to know what day it is, judgment and problem solving, ability to solve problems and do many of your cognitive activities that are needed to do your ADLs. Community affairs, how independent are you in your functioning at your job, at your volunteer activities? Home and hobbies, what kinds of things can you do in the home? What kind of chores can you continue to do? And personal care. And personal care reflects how much help or prompting you need with dressing, with washing, with preparing meals, etc. So this is a really well-established scale. And while many people will say, well, you know, it's not a perfect scale, it's been used for many years and has been very informative to us. So this is the important areas that it is measuring. Now, what I want to do is begin with looking at the study that had a positive outcome. That's the eMERGE study. And what you can see is on this, what we call primary outcome measure, the CDR sum of boxes, there was a 23% reduction in the CDR progression, right? Which is very significant, all right? However, and this is at the high dose. However, what you can see is that there was more or less effect in other measures, activities of daily living, the cognitive scale called the Alzheimer's Disease Assessment Scale Cognitive Version, and the mini mental score. Now, one of the things that's really important, and the FDA made great note of this, is that in fact, in the lower dose, the mini mental score actually got worse in the treatment group. Now, the ENGAGE study showed us something different. And in fact, at the high dose, in a very large number of cases, 555, in the high dose, what you see is even the CDR, sum of boxes, was worse in this group, as was the mini mental. And while the other two scores, the cognitive and the activities of daily living, were in the positive direction, none of them were significant. Now, the second issue that people talk about is, all right, one positive study on some measures at the highest dose, the other study, no positive effects. Now, the second thing that we talk about is the safety. And as I said, we've been referring to this phenomenon of Aria. And there are two types of ARIA, but it's measured with MRI, the magnetic resonance imaging that I'm sure many of you have had or know someone who's had. And we look to the severity of the ARIA, and we look to measure the amount of brain that's showing this hyperintensity or microhemorrhage, right? So these are the three different types of ARIA. A couple of things to keep in mind is that the clinical symptoms were accompanying ARIA in about 25% of the patients at the highest dose. All right. And only 5% of those in placebo. So we know that some ARIA can just occur naturally, but we had 40% in the individuals who had the highest dose. And among those, at least 25% of them had side effects that they knew, not just imaging side effects. The most common symptoms in the patients who were treated with Aduhelm was headache, all right, 13%. But we're going to look closely at these numbers because it's very important. Now, this slide has the eMERGE study and the ENGAGE study together, and there are a few things I want you to see. In particular, I want you to notice that in the ApoE4 carriers, what we see is that the ARIA rate is dramatically higher, 42% versus little under 20%, 18%. And that's in the eMERGE study. And even in the ENGAGE study, where there was no effect, it was almost 42% in the high dose. And the non-carriers had about half of that. And what you can even see is that in the lower dose, there's almost 30% ARIA. So even if you don't make it to a dose that's effective, you have a relatively high likelihood of having ARIA. So overall, the rate of ARIA is twice as high in a person who has an E4 across both studies. So even if there's no effect. Now, the FDA was concerned about this, and the statistician at the FDA did some additional analyses that I think are really important to examine. And what you're looking at is an analysis done by the FDA statistician. And here on this side, we have the ApoE positives, and here the ApoE negatives. And what you're looking at is the effect on the CDR sum of boxes in the two groups separately. And if they go through this middle line, it means they did not differ from placebo. And if they go above the middle line, it means that they were significantly better than placebo. And what you can see is in the ApoE negatives that there was no benefit, that they did not show any benefit on the CDR sum of boxes. However, the ApoE positives systematically showed a benefit with higher scores than the placebo group. So we have a real challenge here. In the group that has an ApoE4, we have a likelihood of a benefit, but we also see that we have a high risk, twice as high as those who are ApoE negative. So the FDA tried to look at some other reasons why you might get more positive response at the higher dose. And what they identified is that up to 35% of the individuals who had a high dose had to have their titration dose change. So maybe they were scheduled to come in once a month and get a certain amount. Well, now they extended that time. And patients and doctors knew if they had to have a change. So they might have known that they had some likelihood of having a higher dose. That breaks the blind, and it may be a reason why we see a difference in some of the outcome measures, because we have a little bit of bias. It's not intentional. No one meant to break the blind. It's what happens when some information slips out. So I think that's a possibility we need to keep in mind.
Dr. Sano, I'm sorry, I'm just going to interrupt because two people had a question, just what you're talking about right this second. To clarify, the relationship of ARIA and ApoE carriers, like the likelihood of benefit and the higher risk of what exactly.
Exactly.
And
Okay.
also someone asked to clarify with the meaning of titration. Does that basically
Oh,
mean
thank you.
dose?
Thank you. I'm going to do that right now. So let me go back and just show you these slides because it's a great moment to do that, right? So what I'm showing you are the percentage, and this is on the slide from the data from the 2 studies. What I'm showing you is the percentage of people who had these MRI abnormalities. And what do we know about the MRI abnormalities? They indicate some likelihood of bleeding. They indicate some changes in the vasculature of the brain, right, in a negative way. And when we see them, we stop medication or we reduce the dose. And the reason we do is because when we don't, we've often seen that people have significant side effects. The mildest of the side effects are the headaches, but there have been individuals who have had strokes and had to come out of the study. All right. So that's what the adverse events are. ARIA are these changes on the MRI, another surrogate marker, but a surrogate marker of some deficits or some problems. And what you can see in this slide is those people who were ApoE4 carriers, 1 or 2 ApoE alleles, and we're going to talk about what each one of them means in a minute, were more than twice as likely to have ARIA than those who were not ApoE carriers, right? So now I know if I have an ApoE4, I have a little bit higher likelihood of having an adverse effect, a change in my brain, possibly a risk for stroke, and likely a risk for headache and other symptoms, right? Do we know what happens if we don't do anything? No, because we would never do that. If you're seeing those brain changes, you have to act, and we do. Now, what I'm also showing you is there another piece of information. Those same people who had the highest risk, they had the highest gain. And in this slide, what you see is that in those individuals, they were more likely to have a benefit in the clinical outcome measures. So their benefit above placebo was significant. Not true of the ones who didn't have the E4. So that's the balance. The benefit and the risk are higher in the E4 group. In the non-E4 group, at least by this analysis done by the FDA, it doesn't look like there's much of a benefit. And then I explained to you that if I have to change your titration, which means the rate at which I increase your dose, remember, we have to slowly go up from no drug to the drug that you need to have an effective dose, right? We know that the low dose didn't have so much effect, but to slowly increase your dose, we'd have to increase it even slower or perhaps stop before we go all the way to the highest dose. So people could know, their medical staff would know that there might be a difference in who these people were. That's what we call breaking the blind. And so I wanted to go back and just remind you, we all know about this apolipoprotein E, and we've had a long history of knowing about it. In 1995, there was an article that said, you know, you shouldn't really use it except in clinical situations where you think it might help figure out whether the person had Alzheimer's or something else. But what we know is that if you have first of all, we know every person has 2 alleles. They get one from their mother and one from their father. And the alleles can be 2, 3, or 4. And we know that if you get 1, 4, your increased risk of dementia is about 3-fold. And we know that if you have 2, your increased risk is more than 10%. I'm sorry, more than 10-fold, right? So these alleles come from our parents, and when we know them, we know something about who had them. We know that one of our parents had them. Maybe we don't know which one. And if we've had children, we know that we may have passed them on, right? Now, There's been some discussion about maybe we should use this because we can know more about people who are in that earlier prodrome stage that they might be at risk for Alzheimer's disease. But now we have this new information. Should we consider recommending the use to predict a treatment effect, both a beneficial effect and a negative effect? But then we have to ask ourselves, what does it mean to know your ApoE status? So, as I said, when you know your status, you know the status of one or more of your biological parents. If you're a double E4, you know they both had an E4. If you know one, you know that one or the other did. And you also know the probability of an ApoE in your offspring. You could have a 50% chance of passing it on to your offspring. So I want to ask you, because we're all dealing with what to do next. Would you want to know, and you have a chance to answer our poll now. You have three choices here. Yes, I would want to know. No, I would not want to know. Or I'm just unsure. I can't tell at this time. And then I'm asking you a second question. When would you want to know your ApoE4 status? At any time or any age, do you think it's something that everybody should know? Or only if you have memory problems? Or only if you had amyloid in your brain? So we are waiting to see what you tell us, and we'll share with you once we answered the poll. But I think what I'd like to do is go on while you answer. Can they answer the poll if we go on, Dr. Sewell?
Yes.
Okay, so we're going to leave the poll up, but I'm going to try to continue and just tell us where we stand. Okay.
So Dr. Luizos, can they continue to answer here? Yeah, there we go.
Okay, good. Oh, but I can't advance. Apparently, I can't.
Okay, so hang on one second.
Okay, we'll show the results and then we'll go on.
Okay. Okay, so as the numbers come in, it certainly looks like the vast majority of responders would like to know their ApoE4 status of the people who have answered.
Yep, and I would ask anyone who thinks that they answered and then it popped up again, just put your answers in again, please.
Yeah, we might have accidentally ended the poll prematurely, so put your answers in again.
So, Dr. Loisos, do you end the polling or do I?
I'll end it.
Okay, great. Thank you. Because I don't think I can advance the slides.
Yeah, I know.
Yeah.
Okay, so it looks like still now that people are
only 51 people have
yeah. Well, some of us are probably not weighing in on this.
Okay, I'm gonna end it.
Okay. So it looks like about 73% of the responders said they would want to know their ApoE4 status. And in terms of when they would want to know it, about 56% anytime, even if they were very, very young. But 33% said they'd only want to know if they had a memory problem. And 12% said they'd only want to know their ApoE4 status if they actually found out they had amyloid in their brain. Okay.
Right.
But 27% said they just don't want to know their ApoE4 status.
All right. That's great. So I'm going to go on and we're going to talk more about this in the end. We may use it to reflect what we decide to do personally. So what I'm showing you is another important page, and that's what are the adverse reactions. And as you can see, the most common adverse reaction is this ARIA. And what you can see is that it is dramatically higher than what you see in placebo. So it is real, and it is on imaging. Headache was more common, and the specific types of ARIA are explained here and shown. The other common Aria adverse event were falls. But what you can see is while falls were higher, they were also high in placebo. And then a few other things are noted. Perhaps more concerning are the confusion, delirium, which is twice as high in the Aduhelm as it is in the placebo. Okay. All right. So I want to provide you with a high-level summary that was given by the FDA statistician. The statistician really felt as though that study really lacked substantial evidence of clinical benefit. It did not address the question of accelerated status or surrogate biomarker. It reported that week 78 high dose changes that occurred, there was no evidence of slowing, no correlation of the slowing and of the PET marker. So that's concerning. There was also no overall evidence, and in fact, conflicting evidence in the two separate studies that were presented. And there is this very big question about safety based on this biomarker of ApoE. So what do we know? We know that Aduhelm removes amyloid, a defining pathology in Alzheimer's disease. There's no evidence at present for clinical benefit. And the FDA acknowledged this. It said it's likely that it could have benefit, and it gave the company 9 years to determine if there would be a benefit, a clinical benefit. There were some trends of benefit at the highest dose and in the ApoE4 group, but not in the other parts of the study. Now, it's important to remember about 60 to 65% of the cohort was ApoE4 positive, but in the other relatively large set, there was no difference in any of the clinical outcomes. Then there's some trends of concern. There's a high rate of ARIA, especially in that ApoE4 group, but it's high in all of the groups. No correlation between the surrogate marker and the clinical outcomes. So it makes us wonder, is it really a surrogate marker? And the low dose had some outcomes that were actually worse than placebo. So we do have things to consider in balance, positive and negative things. What will Mount Sinai do? Well, you probably read many headlines in the news about what major medical institutions are going to do. And some of them have said, we're not going to give this drug, or we're not going to treat, or we don't think that the effect is big enough, or we don't think the cost is right, or we know that there's going to be an investigation of the FDA, and so we're going to wait for all of that. But if you read the fine print, what you will find out is that what Mount Sinai is going to do is it's going to develop best practices to identify the best way to establish a benefit. Who is this most likely to benefit? Is it those with amyloid? Is it those with ApoE4? Remember, right now, I don't even have to be sure a person has amyloid to prescribe according to the package insert. The practices are going to include who's at highest risk. Does it matter what your ApoE status is? Does it change your risk? Does your baseline MRI change your risk? Should some people not take this drug because they have evidence of hemorrhage on their MRI? What's the best way to manage people who have comorbidities and concurrent medications? Many people get very big benefits out of taking their anticoagulants or their blood thinners. Maybe that's more important than taking this medication, and maybe the risks of putting them together have to be weighed. And these are the things that Mount Sinai will be weighing. We'll be weighing how to measure the side effects, including ARIA. This is a big challenge because for all of those studies, it wasn't the local radiologist who measured this. It was a centralized measure that includes some very precise types of measurement of the MRI, something that may not be in place in your community. And what should you do? Well, if you have memory impairment, get it diagnosed. Please see a doctor. Let them decide how much evaluation you should have. Should you have imaging? Should you have an assessment of your amyloid? Always you should have an assessment of your cognitive benefits or your cognitive condition. Are you really having memory problems? This is something you can do and should do. Treat. We have approved medications for Alzheimer's disease. They have been approved for a long time, and we keep finding that they actually have benefits. They delay cognitive worsening, and they delay the time to death. So we know this for a fact, and these are treatments that are available now and will not interfere with whatever else you might take. Manage. Think about all of the behavioral and life factors that you might want to change or manage. So there are things to do, and we should never be nihilistic about this. Keep that in mind. Know the risks and benefits of new treatments. Discuss with your family and friends. What would you want to do if, unfortunately, you were one of the few people who had a stroke, not so few, but people who had a stroke or who had a brain hemorrhage that might have made it difficult for you to do the rest of your life? Listen, read the whole story. There are many headlines. The headline is not always matching the details. It's important that you realize that the information is changing every day. We are not holding out on you. We're getting the information just as fast as you are, and hopefully you can see this today. We're presenting you data that was updated less than 2 weeks ago. So hopefully you know we have information for you. And finally, I want to say that the opportunity to bring you this kind of presentation comes from the research we do at the Alzheimer's Disease Research Center. And it should never be thought that any one person is singly responsible. We have a huge team. Some have changed, but many are the same. We've had a real COVID challenge, but we've moved on, and we're really pleased to be able to help you know what's going on today. And so I'm going to end there.
Great. Thank you, Dr. Sano. So before we take questions, if people aren't able to stay for the question and answer session, we just wanted to get your feedback for these 2 questions here again. We'd really appreciate it. Just how, generally, how you responded to today's lecture so far. And the second being in terms of our upcoming lectures, what kinds of topics you might want to hear about. So if you can just take a second to do those, and then we will start taking questions.
So Meg, how would you like to handle the questions? You want
I'm gonna go through them, and I'm gonna say them out loud for you. I'm gonna take them from the
Perfect.
chat.
Thank you.
And we've got some really good ones. As people are answering, I guess one question that just came in is that people have heard that Mount Sinai is actually not going to be using this medication right now. And if you wanted to comment on,
Sure.
on that, because some places will, but some places have decided not to.
Right. So there's a couple of things to keep in mind. The drug is not freely and readily available as easily as you might think, but it is becoming available, and the company is working hard to get it everywhere it needs to be. Mount Sinai's doctors can prescribe the medication, and you can get it through a wide variety of mechanisms if they feel it's appropriate for you. But Mount Sinai itself has decided it's going to create best practices. I suspect these will be out soon, and the timing of the best practices will be based on daily updated information, our ability to get the drug and deliver it safely, our ability to know who should be the right person to get it, and what the real risks can be, and who those people are who might be likely to benefit and might be likely to have adverse events. So when you read that we're not doing it, that's not exactly accurate. You have to read the fine print. We are actually developing the best practices to do it the safest and most effective way possible. And that is what many of those other centers are saying. Some have said we're going to put a hold on it. We believe that if a drug is approved, it's our job to fully evaluate how to deliver it safely.
Two people asked this, how do we prevent the approval of Aduhelm from impacting recruitment for other Alzheimer's clinical trials?
Right.
How
Well,
this will impact that?
I think that's a good question. You know, the hopefully it's the information we provide to people that will make them decide what is right for them. So as you can see, once a drug is approved, um, a lot of the barriers that might not have allowed you into a clinical trial seem to get dropped. So there may be some people for whom looking for treatment is the right approach. But for people who are really very concerned about the data I've shown you, you may want to wait and see what other trials are available. Those trials may offer you an opportunity to learn your ApoE status. They may offer you an opportunity to have amyloid imaging and to determine if you have amyloid. They may offer you an opportunity to get a very good evaluation of your cognition, of your cognitive impairment. So that's another thing that can be offered by those trials. Even if you're not allowed into the trials, you may be able to collect that information, which could be very important. So I think the weapon to keep us from losing people into research is information, sharing the information and clarifying anything that people don't understand so they can make up their own mind. That's what's most important.
Thank you. Here's another question. Someone was asking, can you contrast aducanumab with donanemab, which I can never say these mabs, donanemab in clinical trials?
Right. So donanemab was used in a slightly different population. It's a somewhat different molecule, but the strength of the published data is that, in fact, on a new outcome measure, one that we have a little bit less experience with, it did show some positive outcome on that outcome measure in a relatively small group of people. Now, the FDA has said every molecule that would like to be considered for accelerated approval has to bring its own dossier for accelerated approval. And so it's possible that donanemab will present its own dossier to ask for accelerated approval. It's also possible it will expand its clinical trials so we can have confidence about the clinical outcome measures.
Okay. Thank you. Here's another question. Is accelerated approval justified in this instance, given that A beta reduction has been shown by many randomized clinical trials to not predict clinical benefit, including these? And what would prevent other companies to file for approval of drugs or antibodies that reduce A beta but failed on the cognitive outcomes?
Right. I think that you've pointed to something very important, and this is really the challenge. It's the accelerated approval was granted by the FDA and was not reviewed by an advisory board. As you can see, Alzheimer experts have created the framework, which is to allow us to evaluate whether or not this is true. And as I mentioned to you, the likelihood of the amyloid change occurring before you see the clinical change is what the framework sort of proposes to us. So that's how it happened. The argument is it's not enough time to see a clinical benefit, and that we would expect that it would follow. But the FDA acknowledges that we don't know that for sure, and that's why they gave the company this 9-year period to see if they can demonstrate clinical efficacy. So the second question about what's to to bring others, nothing. And in fact, I expect that you will see many other agents go to the agency and ask for accelerated approval based on the movement of a biomarker. That's my guess. So only time will tell. Like I say, pay attention, see what's around. The one concern many of us have is the aducanumab data is not yet published, right? So we only have what was released by the company and what was reviewed by the FDA. And so we don't know yet what the exact results are. Some of the other agents have started to publish, and we have a little bit more knowledge about them.
Thank you. Next question was, can differential dropout rates in these studies due to Aria in the E4 carriers versus the non-carriers maybe help explain why Aduhelm appears to benefit the E4 carriers?
That's a very good question. And it's a real challenge, but it's a real possibility. In fact, the ApoE4 carriers really were not initially even brought up to the full highest dose. It was only done later in the study. And if they couldn't get to that higher dose, they may have dropped out depending on the adverse event rate. With other agents, we even know that the highest dose in, for example, with another monoclonal antibody was associated with so many side effects at the highest dose that the EMA in Europe, the equivalent of the FDA here, required that they stop the highest dose in those groups. So in fact, you are right. There may be some limitation of us actually seeing the full negative effect because those with side effects may be dropping out before the end of the study.
Okay, thank you. And I think our last question, they're sort of related. One question was, how does one get an ApoE assessment? And a comment to that person from someone else was that you can, get your own genetic analysis using things like 23andMe. So I just wonder if you want to address those issues.
Right. So, the availability of our genetic information has become quite broad. Many people are able to get this information now. I think one of the big challenges is, do you fully understand the consequences of having that information? So, for example, do you understand what it might mean to your family members or to your ability to do other things? Now, keeping in mind that right now, your genetic status cannot change your ability to get health insurance, although that could change. It does affect other kinds of insurance. And so you may want to do this within the framework of counseling to know what the impact would be on you, on your family members, who are in your same generation, and maybe even of your children. So I think it's really important. And we know that it's a risk gene. It is not a determining gene. And so you have to, again, have a lot of information to weigh, if this is something that happens late in life, what would I change if I knew my ApoE earlier in life? So it's very complex, and I think it's always possible to get this information through your commercial entities, but it may be more valuable to get it with discussions with your primary care physician or other medical provider.
Great, thank you so much. All right, I think, Dr. Sano, that we got through all the questions for now, but as I said at the beginning, if anyone has any follow-up questions, and I responded to a couple of people in the chat, please feel free to reach out. You can call us at 241-8329, our ADRC number. You can email any of us, very easy to find us at Mount Sinai, and happy to get back to you. And again, if you're interested in joining our registry so that you make sure you hear about upcoming talks in our newsletter, just shoot Dr. Luizos an email and we will include you. And I want to thank Dr. Sano for a terrific talk, and thank you all for coming today, and look forward to seeing you at the next one. Bye, everybody.